In this second video on diabetes mellitus treatment, I'm going to review some of the most commonly used hypoglycemic drugs. Most of these are oral agents. A couple of them are injectables, but most of them are oral, and they're mostly used for type 2 diabetes. And then in the last lecture of the series, I'll look at insulin therapy, primarily used for type 1 diabetes and late stage type 2. So the hypoglycemic agents are sometimes referred to as oral hypoglycemic agents. That's again not quite accurate because one of them in particular is injected, but they're used in the treatment of type 2 along with diet and exercise and maybe some of the other adjunctive therapies I discussed in the last lecture. Again, in type 2, a lot of patients in later stage might require insulin, and the way we usually start oral hypoglycemic therapy is to start with one agent, follow the patient's A1C, and then reassess within 3 months. If the A1C is not within our target range of 6 to 7%, then we usually add a second agent in, again reassess within 3 months, and then go up to a third agent if necessary. Usually though, if 3 agents fail, then this is when we consider adding in basal insulin therapy. So that's the typical approach. This is outlined in the guidelines of the American Diabetes Association. So typically our agents will be starting, so looking at the graph at the right here, start hopefully with your diet and exercise and lifestyle modifications, aiming for some weight loss and aiming for a minimum of 150 minutes a week of exercise. And then, for many patients with an A1C, maybe just below 8, somewhere in there, we can just do this for 3 months. If that brings the A1C back within normal range within 3 months, we don't need to go further, just continue with those. But if the patient's still not controlled, then we add Metformin. And so that's going to be our first agent that's typically added, and I'll talk about how some patients cannot take Metformin, but this is usually our first add-on agent as a hypoglycemic agent. It is an insulin sensitizer, but mostly it works by decreasing the production of new glucose in the liver, so decreasing gluconeogenesis. And it tends to decrease A1Cs by up to 2%. So know that when you start a patient on Metformin, you'll see 2%, maybe 1.5% decrease of A1Cs. Exercise and diet alone will tend to decrease A1C by another 1.5 to 2%, or even a little bit higher. So with Metformin exercise, that's about a 4% reduction in A1C right there. Again, if the Metformin after 3 months with the diet, exercise, etc., still doesn't bring the A1C back into the goal of between 6 and 7%, then we're going to add a second anti-hyperglycemic drug, and that would include things like the sulfonylureas. These are second-line agents. These actually tell the beta cells, they trick it into secreting more insulin, so they're really trying to just get more insulin out of the beta cells. They will only be useful for 5-10 years or so, and then the beta cells will start to fail. And so that's why more and more we're seeing these less and less prescribed, because they're really not doing what we want them to do ultimately, which is to improve the insulin sensitivity. So they're not having much effect on the insulin sensitivity. They tend to decrease A1C by up to 2% as well. Newer agents will be the GLP-1 receptor agonists. And these agents, remember, GLP-1 is your small intestine duodenal peptide that's secreted in response to high glucose foods, tells the beta cells to secrete more insulin. So these are peptides, and they are given by injection subcutaneously. And so they're increasing, like the sulfonylureas, insulin secretion. They're typically, though, a second or third line therapy. We do have new data suggesting, though, that these are one of the few agents that actually have long-term cardioprotective effects. So we're seeing a little bit more since these studies came out now of more people on these medications. They have some very important adverse effects, for example, severe nausea for several weeks, even months in some patients, and that's important to know about. SGLT2 inhibitors are the most the most recent class of anti-diabetes medication. And these are, again, second, third line agents. They're going to work by decreasing glucose reuptake in the kidneys, so you essentially increase glucoseuria, and that gets the glucose out. They also lower blood pressure a little bit, and they lower body weight a little bit. So everyone's like, these are fantastic. But in a way, we have problems because, again, we're getting all this glucoseuria that increases the risk for infection and so forth. But these have been studied, and they also have a cardioprotective effect, just like the GLP-1 receptor agonists. And metformin, I mentioned in the last video, also has a cardioprotective effect. Sulfonylureas do not. So I guess I'll do this. They don't inhibit the heart, but they have no cardioprotective effect. DPP4 inhibitors, these are, so DPP4 is the enzyme that naturally breaks down GLP-1. So when we secrete GLP-1 from the small intestine, DPP4 inhibits it. So now they have DPP4 inhibitors. So these are oral agents, so it's better than the GLP-1s that way, but they work less effectively. They have less effect on A1C. I think it's more like 1% or so. I'll show you the numbers here in a coming slide. And so they are also increasing by encouraging GLP-1 activity, increasing insulin secretion. So they're another second or third line agent. And then one final agent I'll just mention here is the TZDs, thiazolidinediones, big mouthful, but there's only one of these medications still on the market. The other one was removed because it seemed to increase the incidence of heart attacks in patients. And so pioglitazone is still on the market, and that is a second or third line agent for type 2 diabetes. Very few people use this anymore because of some of the concern, the safety concern about its the other medication in this class. And so a lot of people don't trust this drug, and so I don't see a lot of practitioners prescribing this, but it is considered a second or third line agent still on the list. And so that's what you see, these little abbreviations. So this is the pioglitazone here, DPP4, GLP-1 receptor agonist, SGLT2, sulfonylurea, and here's basal insulin. You can see what they do on A1C levels. Now, some of the concern is, again, we don't want patients on these therapies to gain weight, but notice that the pioglitazone, basal insulin, sulfonylureas, all increase body weight. And so that's not a good thing. But the SGLT2s, GLP-1s, and so forth do not actually increase body weight. So that's a good thing. And then hypoglycemia, the sulfonylureas, and basal insulin are the two agents that we really associate with hypoglycemic episodes. And then heart failure, you can see the different effects here, but we're seeing basically with the SGLT2 a decrease in heart failure, potentially increase with pioglitazone. So again, that's why a lot of people are not looking at this as a cardioprotective agent, and so we're not seeing much effect there. Basically, DPP4, we see very little effect on any of these. So these are used, but I don't see them used as commonly as the GLP-1s and the SGLT2s and metformin. Those are probably the top three with basal insulin that are now currently being used for diabetes care. There's others that I didn't include here because they're very uncommonly used now. That would be, for example, alpha-glucosidase inhibitors. These are taken with high carbohydrate meals to prevent absorption of carbohydrate. But you've got to take them with every meal, pain in the butt. And it turns out that just eating mushrooms, like maitake mushrooms, things like that, actually do exactly the same thing. So just do that in your diet, or just don't eat all that sugar. Meglitinides would be the Prandin and the Starlix. These augment the actions of insulin, and so those are also usually taken with insulin therapy. They have to be taken several times a day, so these are something that I won't be talking about, but they are technically on the list for the hypoglycemic agents. Okay, so that's a summary of kind of the approach using the different agents. Now we'll go through especially the top three here and look at them in a little bit more detail. So I'll start first with metformin. Metformin is a biguanide. It's also known as glucophage. It's really the first line treatment for type 2 diabetes. very commonly used. In 2006, there were over 35 million prescriptions worldwide, or in the US actually, and this number has just increased since then. Interestingly, this drug metformin it's in this class biguanides. It had another drug, fenformin, in the same class. They were both developed in the late 50s. The parent molecule for both of these is guanidine, and guanidine actually comes from an herb, Galega officinalis, which is in the pea family. This also goes by the name of French lilac. It's used in traditional European French herbal medicine as a diabetic remedy. And we actually have it, for example, in the UNM clinic as a tincture. So I often add it to my formulations. But the guanidine was taken and it was developed into metformin and fenformin. Fenformin was taken from the market because a lot of patients died from lactic acidosis, so they took that off the market. But metformin is still on the market, and one of the potential adverse effects, as we'll see, is lactic acidosis, which is something we need to look out for, but it occurs much, much less commonly than it did in the fenformin. So that is a little history on this drug class. The dosing of metformin typically is to start at 500 milligrams a day, and that can be increased to 1,000 milligrams BID. It acts over 8 to 12 hours. Its maximum effect is at 2 hours. Now, there are two forms of it: immediate release, or IR, which is usually the least expensive. Most of the generic drug plans cover it, and it comes in 500, 850, 1,000 milligram tablets. The typical dose is between 1,500 and 2,000 milligrams a day, and that's usually done twice a day, morning and evening. You can also get extended release. This is more convenient. Comes in 500 and 750 capsules, and typically we take up to 1,500 milligrams a day. But the nice thing about extended release is it will last throughout the day, so I find patients can take a much lower dose than the immediate release tablets. But some of the drug plans will not cover extended release tablets. These are taken with meals. So this is the metformin. Its primary action is to inhibit gluconeogenesis in the liver, which decreases the output of glucose in the liver. You know, it's interesting, a lot of patients with type 2 diabetes, you'll measure their blood sugars in the morning after fasting overnight, and they're really high. And the reason they're high is that the liver now, through the cortisol awakening response and whatnot, has caused gluconeogenesis. And so the liver is putting out all this new sugar, and so metformin inhibits that. Remember, in gluconeogenesis, that there are three primary substrates that the liver can use to make new sugar. One is using lactate from muscles. The other is certain amino acids, glucogenic amino acids. And then the other is glycerol from triglycerides. So those are your three substrates for gluconeogenesis. Well, it turns out by inhibiting gluconeogenesis, you can get a buildup of the lactate, and that's what causes the lactic acidosis, which I'll talk about here in a bit. The metformin also slows the intestinal absorption of sugars. It does slightly improve insulin sensitivities in muscle and adipose by increasing the number of receptors. It helps to improve the lipid profile modestly over a 4 to 6 week period, decreasing LDL, and it again has been shown to decrease overall cardiovascular mortality. Metformin does trigger weight loss, so it decreases appetite, and it's one of the few, again, in that whole class of diabetes drugs that does not induce weight gain. So its net effect is to lower A1C up to 2%, lowers fasting glucose by 25%. It's weight neutral or mild weight loss, decreases cardiovascular risk, and will not induce hypoglycemia with metformin. The adverse effects are relatively rare. It's considered relatively safe, but lactic acidosis is probably the most significant one. And this is going to be increased, especially in patients with any degree of renal failure, but especially in patients with a GFR under 30. So GFR is under 30, we can't give metformin. But in early stage 1 to 3A renal failure, metformin can still be used. but we have to monitor for lactic acidosis, and that would be symptoms of metabolic acidosis. So very similar to DKA in terms of hyperventilation and all the other acidotic symptoms. In the GI system, we sometimes see bloating, fullness, metallic taste in the mouth, nausea, diarrhea, etc. Metformin is associated with vitamin B12, causing vitamin B12 deficiency. So we sometimes give vitamin B12 supplements alongside of metformin. And we see it prescribed in many insulin-resistant states. So even if a person's not diabetic, it's being used for insulin resistance. And so, for example, in certain forms of PCOS, we have insulin resistance, and that can decrease fertility. So if you use metformin, fertility would increase. It's absolutely contraindicated in diabetic ketoacidosis, in chronic alcoholism. So if your patient's an alcoholic, they has an alcohol problem, they can't take metformin because the binge drinking may actually trigger lactic acidosis more commonly. In chronic kidney disease with a GFR under 30, chronic liver disease and cirrhosis in pregnancy, it is contraindicated in pregnancy, and Tagamet, which is of course one of your acid blockers, H2 blocker. This is going to enhance the activity of metformin, so you might get an overdose of that. Not many people are taking those H2 blockers anymore, so that's not too significant. But anyways, this is the kind of actions but also adverse effects of metformin. But again, very commonly used. We generally consider it to be safe. I've used it a lot. I've very rarely, if ever, seen any significant adverse effects from it. But do be aware about the B12 deficiency issue, and that might need to be addressed. Now, 15, 20, 30 years ago, the sulfonylureas were a very widely used class, usually added on to metformin if metformin wasn't effective as a second-line agent for lowering glucose. But these are being less commonly used, and I'll talk about why here in just a minute. There's 3 generations of sulfonylureas. So first generation, the tolbutamide, for example. Second generation, the glipizide. And then third generation, the glimepiride or Amaryl. These, you could say, got more specific, more targeted as pharmacologists developed the parent molecule further. The first generation are rarely used because they led to severe hypoglycemia, and that is one of the main concerns about sulfonylureas is hypoglycemia. It's less than insulin, but still a concern, and so patients need to be educated about this. The other main adverse effect I'll just mention before we get there is weight gain. So unlike the metformin, which is weight neutral or maybe results in weight loss, people can gain weight on the sulfonylureas. Now the chlorpromamide is interesting because it's actually some of the patent remedies from China, the combination herbal remedies, are actually manufactured in pharmaceutical companies and factories. And they're often found they often have different drugs inside of them. There's adulterants. And there was a very well-known sort of blood sugar lowering product out there of Chinese herbs that was found to be very effective at bringing down glucose levels. Patients were actually getting a little hypoglycemic from it. And when they analyzed the product, they found it actually had a first-generation sulfonylurea in it. When they took that sulfonylurea out, the herbs no longer had the same glucose lowering effect. So this is one big problem we have with Chinese patent remedies is the quality control and production, and the fact that many of them actually have drugs added into them. So we need to know if we use those kind of remedies what the source is and everything else. The second generation and third generation tend to lower A1C by up to 2%. Again, Amaryl is a very commonly used one, and the dosages you can look those up. This was first introduced in 1955, and again, they're used as second or third line agents with type 2 diabetes. Now these are sulfa drugs, so if a patient has a sulfa drug allergy, that will need to be taken into consideration. They are technically insulin secretagogues, so they're going to stimulate the beta cells to secrete more insulin, and again, they will no longer work if the beta cells just are no longer putting out insulin, or have been filled with amyloid over time. And we can measure that by measuring C-peptide levels, and we can tell what the insulin levels are. They work best in patients over 40 who have had diabetes for under 10 years. And again, over time, it's kind of like whipping a tired horse. It's the beta cells burn out, and so these drugs will become ineffective after about a decade. There are newer prolonged release formulations that seem to be less able to cause hypoglycemia, but I typically don't use these anymore because of all the potential adverse effects here. So that would include, in terms of adverse effects, the hypoglycemia, as I mentioned, weight gain, again, a lot of common GI symptoms like bloating, gas, and so forth, metallic taste or change in the mouth, and we have a signal showing that they do not decrease cardiac mortality. They might actually increase cardiovascular mortality. So I think overall we're probably going to see sulfonylureas disappear from prescribing, but right now they still are relatively commonly used, so it's important to know about these. Absolute contraindications would be type 1 diabetes, because again, you're not secreting insulin in those cases, any renal or hepatic insufficiency, and again, the sulfa drug allergy. In pregnancy and lactation, they can induce hyperinsulinemic hypoglycemia in neonates, so they over-secrete insulin, and that induces hypoglycemia in the newborn. There can be teratogenic effects and increased fetal growth and size. So we usually these are contraindicated in pregnancy and lactation. So that is sulfonylureas, a second or third line agent, which sometimes is used in type 2 diabetes. Now, another interesting class which is becoming more commonly used is the glucagon-like peptide receptor agonist. These are, again, second-line treatments for type 2 diabetes. They're newer, although many of them are now coming off patent, so their price is dropping, but they have to be delivered by sub-Q injection, so they're not oral agents. We do see that they tend to improve cardiovascular outcomes, and they also do not increase weight gain. And so they are favored because of that. They were introduced in 2012, and they are classified as incretins. And incretins, again, stimulate insulin release. So they mimic the actions of GLP-1 on the beta cells, which increases insulin secretion, decreases glucagon. They also decrease gastric emptying. That gives the stomach and the intestines time to catch up with all the absorbed glucose in the system. The main agents are the exenatide, Byetta, and there's different kits and different durations available. This can get a little complicated. This is if you end up in diabetes care as a primary care physician and you use these agents, you probably want to go through one of the trainings from the different drug reps and whatnot that can help you with that. Things like the dulaglutide, Trulicity, and the Victoza, liraglutide. These are all given at different dosage ranges. Some of them are given daily. The exenatide is given BID, twice a day, but with the kits here, usually it's given one time per week. Same thing with some of these others. They're given one time a week, although Victoza is given daily. And I put this little chart in here so you can see the dosing frequency and so forth. Now, the main adverse effects of GLP-1 receptor agonists would be nausea and other GI effects. Patients can have very severe nausea for up to weeks or a month or more after starting this, and that could be a real disincentive to taking more of it. There is a slight increased risk of acute pancreatitis, and I put a question mark there because that came out in some of the early market surveillance studies, but I don't think that's been confirmed. Increased risk of thyroid cancer, especially in medullary thyroid cancer potentially. And again, there's a concern about potential increased pancreatic cancer. So these are all question marks right now, but as more and more patients use them, we might see more data around that. But these are the GLP-1 receptor agonists. They were originally discovered, there was I think he was an endocrinologist who was interested in this, and he found this peptide in the saliva of the Gila monster. And so he actually made the first extract from Gila monster saliva. So it came from a natural product. And again, because they're peptides, they have to be injected. So pretty significant reductions in A1C, over 2%. no weight gain, and they also seem to protect against cardiovascular disease. The related class would be the DPP4 inhibitors. Again, DPP4 is the enzyme that breaks down GLP-1, and these are oral agents, but they don't work as well as the GLP-1s. They were introduced after 2006. They're used again as second or third line agents, but if you look at their reduction A1C, that's like 0.8% maximum. That's like nothing. And so diet and exercise would far beat that in terms of efficacy. This is another one. So Januvia, the sitagliptin, and so forth. Onglyza, saxagliptin would be some common agents here. Now, interestingly, berberine also inhibits DPP4. So we can say we have a natural DPP4 inhibitor through berberine. So by decreasing the breakdown of GLP-1 and its related peptide GIP, which is also secreted by the small intestine mucosa, this will increase insulin secretion, decrease glucagon secretion, decrease gastric emptying. They're weight neutral, and they have minimal risk of hypoglycemia, but no real benefits that we've seen so far on cardiovascular mortality, or at least not as much as the GLP-1s. So adverse effects, headache, nausea, skin hypersensitivity. Saxagliptin does have a signal for heart failure, and in certain patients, severe joint pain, and again, a question mark around increased pancreatic cancer. They are easier to take, though, than GLP-1s, so I have seen patients on these because of that. But they are an additional agent, second or third line, that can be added if A1Cs are not controlled. And then we come to the newest agents, the SGLT2 inhibitors. These are inhibiting the SGLT2 transporters, which are the transporters in the proximal tubule, which will reabsorb glucose from the ultrafiltrate in the nephron. And so by inhibiting that, you're going to dump glucose into the urine. So they are newer agents. They are oral. They're becoming more widely used, and we have studies showing that they can improve cardiovascular outcomes. They have a net effect on weight loss, decreasing blood pressure, and decreasing blood glucose without affecting insulin, so they don't cause hypoglycemia. So a lot of benefits, not a lot of adverse effects from that. The examples would be the dapagliflozin, the Forxiga, empagliflozin, Jardiance, and canagliflozin, Invokana. So most of these are still on patent because they were just introduced in 2014. And I think most drugs stay on patent for at least 7 years or so. So we're not going to see those go off patent for a while, but they hopefully will and become less expensive. Right now I think they're pretty expensive, but a lot of insurance is covering them because the clinical data that's emerging is pretty positive. To say it mildly, if you go to some of the conferences on these, they're ecstatic about some of the effects. But our A1C effects are still pretty mild, 0.6 to 1%, which is half of what you see with metformin, and again, far less than we see with diet and exercise. So those again diet and exercise should be our fundamental therapies there. We can see again, unfortunately, some adverse effects with this. And that's because of the increased glucose in the urine. So that would be increased urinary tract infections, candidal infections, vulvovaginitis, genital mycoses. That's usually treated with oral antifungal agents. But those would be some really fairly common adverse effects to keep an eye out for if using these or if a patient is on these. Now, there are a few cases of reported ketoacidosis. There have been about 100 reported cases, so that's something to always keep an eye out for with these. Hypoglycemia, there's a minimal risk. Again, we don't think these have a major effect on blood sugar except to just increase glucose excretion to the urine, but that should not induce hypoglycemia. And then hypotension, if a patient's on an antihypertensive, now you put them on one of these and their blood pressure drops too low. Canagliflozin, there have been reports of a couple of patients taking this had to have lower limb amputations because of peripheral vascular issues. and whether or not there was a direct link with that, that's still uncertain. And there's actually been a couple of cases of very nasty genital necrotizing fasciitis in some patients too, but that tends to be downplayed as maybe that was just a fluke, and again, whether that was causative by the drug, that's a big question. But these are again fairly new, and sometimes it takes 10-15 years of post-market surveillance to actually get the adverse effect profiles really worked out. So essentially this is how it works with a lot of drugs. The population is a giant experimental pool, and so I'm thinking we'll probably see more adverse effects with these as we go. There's never a magic bullet in these cases, and so hopefully it won't be too serious. The empagliflozin can't be used if the GFR is under 30, the canagliflozin if it's under 45, and the dapagliflozin if it's under 60. So chronic kidney disease, renal failure is a relative contraindication for these medications. Okay, so that's the SGLT2 inhibitors. Mild effect on A1C, but benefit of increased weight loss, decrease of blood pressure, and then no effects on hypoglycemia generally. So that's the newest oral hypoglycemic agents. So I just want to mention the TZDs or glitazones here. They again are less and less used. I do have a few patients that did not respond to metformin and the typical agents, and so their endocrinologist put them on a TZD, and that would be the pioglitazone or Actos. Rosiglitazone Avandia has been withdrawn from the market in Europe. It was suspended by the FDA here. It's been recently reapproved, but I don't know of anyone using this anymore because there was an increased concern about increased cardiovascular risk, and the troglitazone was withdrawn from the market due to increased risk of hepatitis. So pretty much it's pioglitazone that's still on the list here. This is an interesting drug class, and I put it here because it's one of the few drugs that actually does directly improve insulin sensitivity and does not induce hypoglycemia, and will decrease A1Cs by up to 2%. So good effects there. But again, it seems to do nothing or potentially increases the risk of cardiovascular disease. So that's why we don't see the long-term benefits like with some of the other drugs I talked about. The way these work is they activate a specific receptor called PPAR gamma in adipose tissue, and that causes the oxidation of carbohydrates in cells. It decreases the release of fatty acids into the bloods, increases storage in adipose, and the net effect of that will be to decrease blood sugar, blood fat, triglycerides, but increase weight gain. They tend to improve insulin sensitivity by having anti-inflammatory effects. They also decrease leptin, which unfortunately will increase appetite, but they will also decrease liver gluconeogenesis like metformin, and maybe improve non-alcoholic steatohepatitis, NASH. So those are sometimes, the Actos is sometimes recommended in NASH patients. No hypoglycemia with these, but again, weight gain, potentially increased cardiovascular risk, especially rosiglitazone. Pioglitazone, I think a lot of people are still suspicious about that one. Increased risk of bone fracture, increased potential of macular edema, and then potential hepatotoxicity. So generally it's recommended for these patients that their ALTs are monitored at least once a year. Or every month, a year, and then every 3 months from that point forward. So that again is going to make it kind of a disincentive to use these. Heart failure, kidney liver disease, and pregnancy would all be contraindications for this. So again, very rarely used, but I throw it on here because you still may see some patients taking it. It's good to know why it's being given and kind of what the mechanism for how we think it works is. So I put this table together just to summarize all the agents we've talked about. I put little price tags in there to kind of show what the relative price is. So, our least expensive, very commonly used metformin is one of the first line agent in most cases, decreases hepatic glucose production, lowering A1C by up to 2%. And the advantages is weight loss or weight neutral, no hypoglycemia, and potentially decreases cardiovascular disease risk. Disadvantages, lactic acidosis, the big one, and vitamin B12 deficiency. And then contraindications in chronic kidney disease after stage 3, so starting 3B, stage 4, stage 5. So GFR under 30. Sulfonylureas, inexpensive, and again, usually we use second or third generation agents. They increase insulin secretion, lowering A1C by up to 2%. They tend to decrease microvascular risk. They're convenient to take, but no real benefit on cardiovascular disease, and we see weight gain and potentially severe hypoglycemia with these remedies. And then there's always that risk of beta cell exhaustion over time. GLP-1 receptor agonists, expensive, but again, as they come off patent, hopefully that should be less. The problem with these is that because they're injectable, the companies can patent the injection method, and so that makes it difficult for a company to copy that and make a generic out of it. But the GLP-1 agonists, exenatide, liraglutide, they increase insulin secretion, they decrease glucagon, they improve satiety, so they are associated with weight loss, and they preserve the beta cells, unlike the sulfonylureas, and they're cardioprotective. And they give a lowering of 1, again, it was a little higher, up to 2%. And then, potential pancreatitis, though, and the pancreatic and thyroid tumors is possible with these as well, and they're by injection, so that's not something a lot of patients will want to do. DPP-4 inhibitors, expensive, but they are oral agents. They inhibit DPP-4, which then keeps more GLP-1 around in the body, and no hypoglycemia, but potential, again, pancreatitis here. And very little effects on A1C. And then SGLT2s, the new darlings on the block, very expensive still on patent, but they have a relative effect by increasing the spillage of glucose in the urine, of not causing hypoglycemia, but causing weight loss, decreasing blood pressure, they're cardioprotective. Rarely, though, we might see the ketoacidosis, but also potential for UTIs and genital mycoses with the SGLT2s. And then the other ones are very less commonly used, so I won't go through those. But this is kind of a list of the typical agents, again, of these. We're probably going to see, we're not seeing the DPP-4s used all that much, and then the sulfonylureas, I think, will become less and less. Although in some community clinics and whatnot, where the more expensive agents can't use them, sulfonylureas still have a place there, and so I won't cross that out. But basically, we're finding the biguanides, the metformin, the GLP-1s, and the SGLT2s are kind of the three biggies. And then if patients don't respond to those, then a patient is switched on to insulin therapy. And finally, here's another summary chart from the American Diabetes Association, talking about what I just summarized, and we talked about the diet and exercise, the first line therapy of metformin, and then second line going to sulfonylureas, TZDs. They still have TZDs on there, DPP-4s, SGLT2s, GLP-1s, and then insulin. And then third line's adding on a third agent there. And then if that fails, then we go generally to basal insulin. So we'll do mealtime basal insulin, and then potentially mealtime insulin. Now, usually when patients are transitioned to insulin, we keep them on metformin, I should say that. So metformin is still kept into that protocol, but the other drugs are typically dropped as well. One combination I have seen some patients on is metformin now, basal insulin, and the GLP-1 receptor agonist. Again, that has to be injected like the insulin, so that's 2 injections the patient has to take. Okay, so that wraps it up for the oral hypoglycemics, mostly oral, for type 2, primarily for type 2 patients, diabetes type 2. In the final video, I'll do a little summary of insulin therapy.